Hi students, myself Babita Matthew. Today I am going to discuss about the topic destructive operations. The destructive operations are designed to diminish the bulk of the fetus so as to facilitate easy delivery through the birth canal. So this is destructive operation. So destructive operations are usually done when the baby is dead. So after the baby dead, it is very difficult to deliver the baby in the normal vaginal method. So when the baby is dead, we are deliver the baby by diminish the bulk of the fetus. Then we can deliver by the easily with the birth canal, normal vaginally. So this is the destructive operation. So different methods we are using for the destructive operations. Let us see each one in detail. So the different types of operations usually we will done are craniotomy, evisceration, decapitation, cledotomy. These are the four methods usually used for the destructive operations. First, craniotomy. Craniotomy, the word itself denotes cranium, craniotomy, it's opening of the cranium. It is an operation to make the perforation on the fetal head to evacuate the contents followed by extraction of the fetus. So we are opening the cranium and evacuating the brain matter, then extraction of the fetus is doing. That is craniotomy. Indications are cephalic presentation, producing obstetrical labor with the dead fetus, and hydrocephalus even in the living fetus also we will do. Then interlocking head of the twins. These are the indications. Next, conditions to be fulfilled prior to the procedure. The cervix must be fully dilated. The baby must be dead, hydrocephalus being excluded. Contraindication. The operation should not be done when the pelvis is severely contracted so as to shorten the true conjugate to less than 7.5 cm, that is 3 inches. In such condition, the baby cannot be delivered, as the bimastoid diameter, that base of the skull of 7.5 cm cannot be compressed. That's why we cannot do the craniotomy. Then normal delivery. Then rupture of the uterus where laparotomy is essential. In that condition also we will not done the craniotomy. So these are the contraindications of craniotomy. Next we can see the procedure. First, preliminary. It is same as in the general procedure. Anesthesia. Usually general anesthesia is used. In some cases the operation may be performed with intravenous diaphragm sedation. The patient is to be placed in the lithotomy position and full surgical asepsis is to be taken. Surgeon is to wear sterile mask, gown and gloves. Vulva and vagina are to be swabbed with the aseptic solution to make the sterile area. Cervix is cleaned with povidone iodine solution. Then perineum is to be draped by sterile hall towel and legs with the leggings. Then empty the bladder. To empty the bladder, if the patient is ambulant, it means that if the patient can walk, she is asked to empty the bladder before she is placed in the table. Otherwise, we can do the catheterization. Then vaginal examination should be done to know the presenting part. Then actual step, that is step 1, the two fingers, that is the index and the middle finger, are introduced into the vagina and the fingertips are to be placed on the proposed site of perforation. However, when the suture line cannot be defined because of big caput, the perforation should be done through the dependent part. When the site of operation is in vertex on the parietal bone either side of the sagittal suture, is avoided to prevent collapse of the bone, thereby preventing the escape of brain matter. So in the vertex, we have to use the parietal bone. Then face through the orbit or hard palate can be used. Then the brow presentation through the frontal bone. So these are the site of operation. So first we have to introduce 2 fingers according to the site of operation. We have to touch the site. Then second, we have to introduce old ham perforator. Just now I am showing the scissors. The old ham perforator. In the old ham perforator, it is open means it is closed. Tip is closed when the blades are open. So when the blades are closed, the tip are open. That is the old ham perforator's normal method. These articulated sides, this open side, if it is normally open, so the tip will be normally closed. When we try to close the handle, then the tip will be open. That is a normal old ham perforator its mechanism. So we are introduce the 2 fingers, that is index and middle finger. Then the blades are closed and introduced under the palmar aspect of the fingers, protecting the anterior vaginal and the adjacent bladder until the tip reach the proposed site of perforation. Then step 3, by rotating movements the skull is perforated. During this step, an assistant is asked to steady the head or abdomen in a manner of first pelvic. Well, how we are doing the first pelvic breath, the same method we have to ask the assistant to hold the head and fix in the pelvis by the assistant. This person who are doing the procedure, they have to keep the finger inside. Other person can hold the head. Then after the skull is then perforated, the instrument is pressed up to the shoulder and the handles are approximated. So when it is reached, then we have to oppose. That means the handles are closed. So when we are closing, the tip will be open. So the tip will be open as to allow the separation of the sharp blade to about 2.5 cm. This is the old ham perforator. Just now I told you. So it is closed means it is open. The handles are open. It is closed. So when we are trying to close the handle, it will be open. This is the old ham perforator. So the blades are opposed to separate the handle. The instrument is bored out, keeping the tip of the blade still the inside. When we inserted inside the cranium, we are trying to close the handle. So that time the tip will be open. Then the instrument is rotated. Then again after the opening, there will be a cut formed like a straight cut. Then after the cut is formed, we have to close the tip. Again we can turn to this side. So again we are trying to open. So again when we are opening, so the cut will be like a cross cut will be formed. That is, the instrument is rotated in the right angle, then again thrust up to the shoulder. The handles are once more to be compressed as to separate the blades for about 2.5 cm. So a cut is formed in the crisscross fashion, that is cross fashion, 2.5 cm up and down, and laterally 2.5 cm. So there will be a cross is formed. The perforated area now looks like a cross. The instrument with the blades closed is then thrust in beyond and God tune the brain. So we can again go. It can be further bring inside. So again we can try to cut the brain matter. So the brain matter also we can cut it. Okay. Then got the chew on the brain matter. The instrument with the blade close is broad. Then when we are bringing out, should be close. Otherwise the vaginal area or cervical area can become injured. That's why we are close. Then bring out under the guidance of same 2 fingers till place inside the vagina. The 2 fingers always keep inside the vagina. Otherwise there is a chance of cut into the perineal area. You can see from this picture, this is closed, 2 fingers are inside the vagina and the old ham perforator is inside. So the handle are open. When we are trying to close the handle, the tip will be open. So that is cut is formed like this. Then with the fingers, brain matter is evacuated. The area is to be make the skull collapse as much as possible. We can tune the inside matter. When the skull is found sufficiently compressed, the extraction of the fetus is achieved either by using a craniograft. This is the craniograft. So we can compress the cranium. Craniograft or two giant wall cells. This is the giant wall cell. You can see from this picture, two giant wall cells are used to hold the inside head and scalp margin. So we can bring out the head. Then the traction is now exerted in the same direction. So same like a forceps delivery. I showed you later previous classes. So same like forceps operation, we can deliver the head by steady traction, then upward traction we can take out the fetal head. And after the delivery of the placenta, the uterovaginal canal must be explored as a routine for evidence of rupture uterus or any tear in the vaginal or perineal area. Then after the same like the normal delivery, we have to give injection methodin 0.2 mg intravenously with the delivery of the anterior shoulder. The rest of the delivery is completed as in the normal delivery. Then forceps as was craniotomy in the dead fetus. So we can use the forceps other than the craniotomy scissors. We can use the forceps and we can do the complete without much force with the consequent injuries in the fetus, and forceps delivery is preferred, but it is found difficult and damaging to the mother, and craniotomy is the safe one. Next we can see the decapitation. Decapitation, from the word it is the cutting of the head. Cutting of the head, that is a decapitation. It is a destructive operation whereby the fetal head is severed from the trunk and the delivery is completed with the extraction of the trunk and that of the decapitated head for vagina. So that is we are severing or separating the head from the trunk and delivering the body part and the head separately. That is a decapitation. You can see from the picture there is a hook is used to hold the neck, and we are cutting the separating the head from the trunk and delivery. So what are the indications? Neglected shoulder presentation with the dead fetus where neck is easily accessible. So if the shoulder if the neck neglected shoulder presentation and dead fetus is there, then we have to cut the head, because usually it will be in the transverse presentation. Then interlocking head of the twins. These are the indication. Then procedures are preliminary, same as in the craniotomy. Same preliminary should be done. The actual steps are: the step 1, the fetal head is not hand is not, if not prolapsed, what bring down a hand. We can bring down a hand and a roller goose is tied on the fetal. അപ്പോൾ ഒരു കൈ പുറത്തോട്ട് വന്നിരിക്കുകയാണെങ്കിൽ ആ കയ്യിൽ ഒരു റോളർ ഗോസ് കെട്ടിയിട്ടുണ്ടെങ്കിൽ നമുക്ക് ഇങ്ങനെ വലിക്കാൻ പറ്റും. അപ്പോൾ കയ്യിൽ കെട്ടിയിട്ട് ഇങ്ങനെ വലിക്കുമ്പോൾ ആ കഴുത്ത് ഭാഗം ഇങ്ങനെ തള്ളി പുറത്തോട്ട് വരുന്നതായിട്ട് കാണാൻ പറ്റും. The wrist and an assistant is asked to give traction towards the side away from the fetal head to make the neck more accessible and flexible. So we can be more easily see the neck. So then only we can cut the neck. The two fingers of the left hand middle, same as in the middle and middle fingers, are introduced with the palmar surface downward. This is the palmar surface downward, and the fingertips are to be placed on the superior surface of the neck. The superior surface, the upper surface of the neck, and proposed site where we are planning to decapitate. Then the decapitation hook and knife is this is the decapitation hook and knife. You can see the hook. This is hook. This is the, here is the blade part and this is the hook. Okay, so the hook and knife is to be introduced, flashed under the guidance of the forces and placed in the vagina, and knob pointing towards the fetal head. You can see the knob. The knob is pointing towards the fetal head. The hook is pushed above the neck and rotated to 90 degrees so as to place the knife firmly against the neck. Then internal fingers, we already keeping 2 fingers inside, and the same in the meantime are placed into the underside. So when it is hooked in the neck, we are keeping the 2 fingers in the underside. So we can touch this tip. Okay, place the underside of the neck to guard the tip of the hook. We can touch this tip of the hook. Then step 4, by upward and downward movement of the hook. So it is hooking the neck. If it is neck, we are hooked this one like this, so tip will be down. So upward and downward movements of the hook and knife, the vertebral column is severed, and the rest of the soft tissue left behind may be severed by the same instrument or by embryotomy scissors. While removing the decapitation hook, it is to be pushed up, rotating to 90, and then to take out under the guidance of internal fingers. Otherwise, there is a chance of injuring the perineum. The decapitated head is pushed up, and the trunk is delivered by traction. We already tied the prolapsed arm. A gauze is tied in the prolapsed arm, so we can the same hand is out and with the gauze traction. So with that traction we can deliver the whole trunk, then we can deliver the head. Then delivery of the decapitated head, any of the following methods may be used. It is effective by hooking the index finger into the mouth, by holding the severed neck with the giant valsellum, and delivery of the head as that of after coming head of the breech. Then using the forceps, we can use the deliver the head. Then step 6 is routine exploration of the uterovaginal canal to exclude rupture of the uterus or any injury to the uterovaginal canal. Next is the evisceration. So that is the third procedure, that is evisceration. The operation consists of removal of thoracic and abdominal contents piecemeal through an opening on the thoracic or abdominal. So we are making an incision in the thoracic cavity or abdominal cavity. We are opening and we are removing the thoracic content and the abdominal content. The body will be the bulk will be diminished. Okay, the objective is to diminish the bulk of the fetus, which facilitate its extraction. And if difficulty arises, the spine may have to be divided. That is spondylotomy with the embryotomy scissors also can be done. This is evisceration. Evisceration means the removal of thoracic or abdominal content piecemeal through an opening to the thoracic or abdominal cavity. The indications are neglected shoulder presentation with the dead fetus, the neck is not easily accessible, and the fetal malformations such as fetal ascites or hugely descended bladder or monsters. In these conditions, we are usually done the evisceration. Next is cleidotomy, clavicles, cutting the clavicles. That is the cleidotomy. Opening, we are cutting the clavics. Okay. The operation consists of reduction in the bulk of the shoulder girdle by dividing one or both. We are cutting the clavicles. So this diameter will be this clavicle. This separation should be diminished. So the operation consists of reduction in the bulk of the shoulder girdle by dividing the one or both clavicles. The operation is done only in the dead fetus and anencephaly excluded with the shoulder dystocia. The clavicles are divided by embryotomy scissors or long straight scissors introduced under the guidance of left two fingers placed inside. We already explained in before pre-procedure. We already explained how the two fingers are introduced. Same like that, we have to introduce two fingers with the guidance of two fingers. We can introduce the scissors, embryotomy scissors, and cutting the clavicles. So we can cut the clavicles and separate the delivery will be completed. And so that's about the cleidotomy. So just now we seen 4 methods used for the obstetric operation. Now we can see the post-operative care following the destructive operation. Exploration of the uterovaginal canal must be done to exclude rupture of the uterus or lacerations on the vagina or any genital injury. So we have to always, after every procedure, we have to explore the uterovaginal canal to check for any injury. A self-retaining Foley's catheter is to be put inside, especially following craniotomy, for a period for 3 to 5 days, or bladder tone is regained. Dextrosaline drip is to be continued till dehydration is corrected, and blood transfusion must be given if required. And ceftriaxone 1 gram IV infusion is given twice a day, because we are doing different type of manipulative procedure, so there is a chance of infection. That's why ceftriaxone 1 gram IV infusion is given twice a day. The complication may arise sometime, that is injury to the uterovaginal canal, we already explained previously, and rupture of the uterus, postpartum hemorrhage, atonic or traumatic, shock due to blood loss or dehydration, and there is chance of prepudial sepsis, chances of involution, injury to the adjacent viscera like bladder, vesicovaginal fistula, or rarely to rectal wall leading to rectovaginal fistula. Then prolonged ill health. These are the main complications may arise due to destructive operation. That's all about the destructive operation. We discussed about the types of destructive operation: craniotomy, cleidotomy, evisceration, and decapitation.